Good morning. I'm Alexis, Holland, and I'll be presenting on our outcomes after open parastomal hernia repair at our high-volume center. These are our disclosures I have to share. Parastomal hernias are a frequent complication that occur up to 50% of the time after stoma creation. Repairing them in a durable fashion is an even more challenging task. And because of this complexity, there remains pretty significant heterogeneity in repair. The predominant approaches include repairing reversal, ostomy residing, or an inside to repair. Mesh can be used, but primary suture repair is still performed in certain situations. Additionally, these procedures can be done in a minimally invasive manner or an open fashion. And further, mesh type, location, and technique varies. There are no formal guidelines on parastomal hernia repair, so the best technique remains unclear. The present study compares short and long-term outcomes after 97 open parastomal hernia repairs at our tertiary hernia center. The primary outcome was recurrence, secondary outcome was overall wound complication rate, and our goal was to compare repair techniques. The demographics of our patients are seen here. Specifically, the average age was just under 62 years old, and stomas were most commonly colostomies followed by ileostomies. 41.2% of these hernias were recurrent. Of our patients, 13.4 were able to be reversed. 25.8 had their ostomies resided at the time of repair, and 60.8 of patients had their hernias repaired with the ostomy left in situ. Of the patients reversed, 46.2 still had a biologic mesh reinforced over the fascial closure at the prior ostomy site. The resided group has two potential sites for recurrence, and you have to measure outcomes at both locations. At the prior stomal site, 92% of patients had their hernia fixed with mesh in either a preperitoneal or retrorectus fashion. At the new stoma site, 84% had a prophylactic mesh placed. These were all biologic meshes and were either placed in a keyhole or sugar baker fashion. Most patients had their parastomal hernias repaired with the ostomy left in situ, with 11.9% undergoing a suture repair that involved tightening the fascial opening. 88.1% underwent a mesh repair with either a keyhole, sugar baker, or onlay technique. Of all the mesh in situ repairs, 55.8 were repaired with a biologic mesh. The preperitoneal plane was the most commonly used mesh location for both the keyhole and modified sugar baker techniques. The overall observed recurrence rate was 20.6% over a follow-up of over 2.5 years. The wound complication rate was 18.6%. When looking at outcomes by repair approach, there were no recurrences in the reversal group and none in the resided without mesh, compared to a recurrence rate of 34.8% in the resided patients with mesh, 42.9% in the in situ repairs without mesh, and 17.3% of the in situ repairs with mesh. The difference in these rates was significant. Then, when taking a closer look at each repair approach, there were 8 total recurrences in the resided group, but none of them occurred at the former ostomy site. Actually, all recurrences occurred at the new stoma site, whether they had a prophylactic mesh placed or not. Of the in situ repairs, the recurrence rates for mesh technique were not significantly different. Mesh location, however, did impact recurrence. Retrorectus had the highest recurrence rate at 50%, and preperitoneal had a recurrence rate as low as 6.5%. Ostomy type did not significantly impact recurrence, but urostomies were more likely to develop a wound complication than colostomies. We then performed a multivariable regression. While controlling for several factors, as you see here, we did not identify any independent predictors of recurrence or of wound complications. We understand that 97 is a small sample size, yet this study still represented one of the single largest series comparing open parastomal hernia techniques. It's difficult to make sound conclusions about the optimal parastomal hernia repair. Ultimately, we would recommend reversal when feasible. When reversal is not an option, recurrence was highest after in situ primary repairs. We did not note any wound complications after primary repair. However, the highest recurrence was found in this group and should be avoided except in limited situations. Prophylactic mesh at residing did not impact recurrence, but preperitoneal mesh location during an in situ repair did lower recurrence. In conclusion, there remains no clear best technique for open parastomal hernia repair. The surgical community needs higher quality evidence in order to make conclusions on the optimal management. Until then, we hoped that the results from our study can guide preoperative discussions and inform risk assessment. Thank you.